Hi, everybody. I'm Vidit. I work at Children's of Alabama in the pediatric ICU. And I was hoping to go through a little bit about gastric ultrasound, which I think for most purposes is more of an introduction than an in-depth review of this subject. Thank you so much, Eric and POCUS, for putting this series together and giving me this opportunity to talk about this. So I don't have any disclosures about this. I've put together two questions on the subject that we're going to try and answer through the course of the lecture. And so if people want to take a few minutes to scan the QR code and answer these two questions, that would be amazing. Thank you. To get for something, you guys were good, then I can move on to the slides.
Okay, let's do this.
Can one of you all let me know if the QR code was working and if you were able to answer the questions, like if you had enough time to go through the questions? Okay, all right. So I guess we're gonna get started. So just about anything I think we do, not just with POCUS, but just in general in medicine, is why should we do it? So the way that I think about gastric ultrasound is it could be helpful to assess the NPO status or not of a patient in three distinct conditions. One is if you're unclear due to lack of communication or urgent nature of a situation. And from time to time, we have situations where we need to decide if the patient is truly NPO in a pretty urgent manner and act on it. For patients that have either delayed gastric emptying or some other reason for abnormal emptying, maybe some postoperative ileus, so on and so forth, or if there is just unreliable or poor history in general. Some of the evidence that comes with this is, I think, actually pretty rich evidence that honestly, before like I started looking into the stuff, I wasn't really well aware of. So there was this scoping review published in Frontiers in 2022, which looked at over 70 pediatric studies that had evaluated the role of gastric ultrasound in pediatrics in one form or fashion.
Progress.
Can you all your mics? Thank you. So like I said, there were over 70 pediatric studies that were evaluating gastric ultrasound in some form or fashion. About 47 of these studies were to assess gastric volume and emptying. They were done by a wide plethora of physicians, including neonatologists to surgeons, showing that this is a pretty valid skill that can be easily adopted. Almost all of the studies argued that this had a pretty rapid learning curve, and has been my experience as well, and had high accuracy in answering the question that was being asked. In terms of probe choice, just like most other skills in pediatric patients, you could do it with a linear probe for most of our younger patients. And then some of our bigger patients, a curvilinear probe might be more reasonable choice. To go through a little bit of stomach anatomy and what we're going to be looking at when we look at the sonoanatomy, typically the stomach is held onto these four big organs by four ligaments: the gastrohepatic ligament connecting it to the liver. Along the greater omentum is the gastrocolic ligament connecting it to the transverse colon. Then the gastrosplenic and the gastrophrenic ligaments are the few other ones. So more or less, the stomach is in a very predictable position, and there are these few different other structures that use as a pretty good guide to where you are and what to look at in trying to assess the stomach. And as we can see, the esophagus opens into the fundus of the stomach, then onwards to the body, and finally the gastric antrum, which further goes on to form the pylorus opening into the duodenum. You can see these rugae or folds that are pretty distinct from anything else that you see in the rest of the intestinal tract, and helps understand or look at when you see a structure to decide if it's stomach or not. In terms of probe positioning and placement, based on what part of the stomach you're looking at, the probe placement is a little bit different. So starting from the left of the screen, you see, to evaluate the gastric antrum, which is often the most easily imaged part of the stomach, you place the probe in a parasagittal plane in the epigastric area. And usually you tend to be a little bit towards the patient's right, so that you can use the liver as the acoustic window and use that as sort of your guide to what you're seeing. And then a small clockwise or counterclockwise adjustment might be needed to image the antrum. And in this view, the antrum is going to be imaged in its transverse axis. So it's going to look, if it's collapsed, it's going to look like a donut or a target sign. To image the body of the fundus, your probe is in a similar position, except that it is directed towards this left subcostal margin. And then again, you're going to have some small clockwise or counterclockwise rotations. And you could be anywhere from being oblique to being completely transverse based on how the stomach sits in the body. And then finally, the fundus, I find when there is something in the stomach, it becomes really easy to look at it. But there are other times when the fundus can be a little bit harder to interrogate, especially if you are using the intercostal spaces, which are narrow in pediatrics. The other place you could use is you can take the probe from this intercostal area down to where you would do your left upper quadrant view through the spleen and direct the probe more anteriorly towards the fundus of the stomach. So looking at some sonographic images of what the gastric antrum looks like and what we expect to see. So this is with a curvilinear probe. Your probe is in that parasagittal plane that we were talking about. From the top of the screen to the bottom, you see the skin, the rectus abdominis muscle, the tip of the liver. Here is the gastric antrum, which in this image is after a patient has fasted for a while, and it looks completely collapsed in itself. So it looks like that nice donut sign. You can see a little bit of shadowing of the pancreas here, the aorta, and then the superior mesenteric artery over here. As the stomach starts to have something that distends it, either liquid or solids or whatever, it starts to change in shape. And then the shape it takes can be just about anything. Here it looks a little bit more circular or elliptical in shape, and then the same landmarks that we were seeing in the previous images, you could see. Here is another example where in the image on the left, you can see that the gastric antrum is completely collapsed on each other, on its, not each other, excuse me, on itself. And you can see here the probe is not really in that transverse plane. It's a little bit more in the longitudinal plane. So instead of looking like this donut sign, it looks more elongated here. And then on the right is an image after the same patient had been given a 500 cc liquid meal, which is clear liquid, and imaged after that. Unfortunately, more often than not, what I see with this gastric imaging is what you see in the picture here on the left. So more often than not, our patients will have some sort of feeds going through mixed with a little bit of air. And we know that air is an enemy of ultrasound. So you start to see these hyperechoic air reflections, and then some shadowing behind that, this dirty shadowing. So more often than not, the anterior wall of the stomach becomes easily identifiable, but the posterior wall of the stomach, you may not be able to see it well. And that's where, even though you can see that there is something in the stomach, you might not be able to assess what the volume of that is. And how to assess the volume, we're going to talk in a second here. What has been shown to help in the studies is if the patient were to go in a left lateral or a right lateral decubitus position. Most of the studies that I've looked at seem to have right lateral decubitus position. And once you do that, the posterior wall of the stomach starts to become a little bit more apparent, and then you can use these to measure gastric volume. This is an example of gastric antrum and what it appears like after a solid meal. It's pretty clear, pretty obvious. Another example of gastric antrum after a solid meal. Moving on to what the gastric body appears when it is empty, we can see it looks like a little bit of a finger-like projection. Here, the image is more aligned with the long axis of the gastric body. And we can't really see the rugae that well, but we can pretty clearly see the multiple layers of mucosa and musculature that the stomach has. And we can see that this looks to be completely collapsed on itself. So we know now how to place the probe. We know what the gastric antrum and the fundus are going to look like. So let's think about how do we actually measure the volume. So in the gastric antral view, most commonly in the right lateral decubitus, but if you can find the posterior wall in the supine position, you can do it in that position as well. You try to measure the craniocaudal and the anterior-posterior diameter. You can use either the two dimensions method and multiply them together to get the cross-sectional area, or you can just trace the area around the gastric antrum. And then you plug it into this formula. This formula comes from a paper that looked at about 100 pediatric patients and then did a regression analysis to come up with this equation. This website, I want to give a huge shout out to the website that makes it actually pretty easy to learn gastric ultrasound and think about it in a way that's practical and applicable. So it's gastricultrasound.org. And the two physicians who built the website are also the ones who did the initial study with the 100 pediatric patients. So you could go to the website and look at that original paper if you want. But here is a very interesting approach to assessment of gastric volume and what to do about the information you get from that. So usually pre-anesthesia, you look at the gastric antrum in a qualitative manner, and you decide if the stomach is either empty, it has just clear fluids, or solid. If the patient stomach is empty, then it's low risk and you proceed with the case as you normally would have. If you have solids in there, then that puts a patient at pretty high risk, and ideally you would like to avoid the procedure if it's an elective procedure, or use precautions if it has to be done in an emergent manner. And then with clear fluid, you measure the volume based on the formula we just talked about. And then if the volume is less than 1.5 mLs per kilo, this is considered as grade 1. It's considered as low risk gastric volume, and it's okay to proceed with the case. And then if it's higher than that volume, then you have to use caution while approaching that. What this website did even more to help us simplify this whole equation a little bit further is they put out this table where, based on the right lateral cubitus cross-sectional area and the age, you can predict exactly how much volume there is in the stomach. On that note, I want to take a couple of minutes to see if anybody had any questions or wanted to relook at some of the pictures before we move on to placement of nasogastric tube. If anybody currently uses gastric ultrasound in their practice and has any stories to share about their experience as well, those would be helpful as well. If not, we can keep moving on with discussion through nasogastric tube placement.
I know that it's routinely used in some anesthesia environments. I do see Ryan Goods on the call. Not to call you out, Ryan. I understand that the anesthesia providers at Trons of Colorado use it in their routine workflow to try to figure out NPO status before a kid goes back from the pre-op area to the OR.
Oops. Yeah, sorry. I'm eating lunch, so apologize. But I don't think it's routine. I know there's a handful of anesthesia providers here that do it, but I think the use is definitely growing. And but I can certainly look into see like how widespread it is.
And apologies again, didn't mean to indicate you there, but yeah, I think the attention is growing. At least at some point, I thought peds anesthesia was starting to use it on their oral boards and stuff, or to talk about on their oral boards and stuff like that. At least some folks who are more ultrasound friendly have been widely supportive. So it sounds like a area we're going to hear more and more about.
And it's a pretty easy skill to learn right away. So I think that really helps its use case and the advantages that it can add by including this in the assessment. So thank you. Thanks, Ryan. And thank you, Eric, for that. We're going to keep moving and talk through the second part of our talk, which is assessment of nasogastric tube placement. So again, why should we do it? Gastric ultrasound is pretty quick and rapid way to confirm NG placement. And we know that a misplaced NG can, even though it's not like a super rare event, but it can definitely cause these unwanted effects, which can be easily avoided. And we know how many X-rays are obtained almost daily to confirm placement of nasogastric tube. So pretty strong use case, in my opinion, for gastric ultrasound here. The technique that I kind of like, and the one that I think is the easiest to follow, is the one described in this paper in Chest in 2021. So this was a pretty large group of adult centers that did a multi-centered study on ultrasound-guided NG tube placement. There were about 8 centers which had about 20-25 providers from 1 to 25 years of experience, who all had this standardized training for 10 hours on how to assess NG tube placement. They looked at a total of 526 NG tubes that were placed in that study time frame. They right off the bat said that 7.6% of these were inconclusive. We have no idea where the NG tube is actually present in these, and I think that's fine. But what's more interesting is that the ones that they were able to locate, the test characteristics for those were pretty remarkable. So let's go through what this process looks like. So they provided a nice little this diagram or a flow chart to think about it. So what they talk about is you do this ultrasound scan, and are you able to visualize nasogastric tube in the stomach as a single or a double hyperechoic line? If you are able to, then that tells you that your NG tube is in a good location. But more often than not, it is really hard to see the NG tube directly. So when you don't really see that, you proceed to your next step, which is injecting about 40 cc's of air through the NG tube and looking for dynamic fogging in the stomach. Remember, these were all adult patients, so 40 cc's of air is not that much. It would be probably a big deal for pediatric patients, but it didn't seem like a huge deal for any of these patients. So anyways, if you see some dynamic fogging in the stomach, then yes, the NG tube is in an okay location. And if you didn't see that, that led them to believe that it was misplaced. And then we looked at their numbers in terms of sensitivity and specificity. Here are the views that they used. We talked about the parasagittal transverse view. They turned the probe 90 degrees in that position to find the gastric antrum in this finger-like projection. Here in the first picture, the gastric antrum is clearly empty with the walls, anterior posterior walls collapsing on itself. And the second picture, we see it with a little bit of clear fluid that's present. This is the view that we were more familiar with and we looked at in the first part of the talk, which is in the parasagittal view in the transverse axis. And the gastric antrum seems to be not completely empty here, but definitely more full in the second image than the first one. And then the gastric fundus we talked about is imaged from either the intercostal or transsplenic view. So these were the three views that they did. And then if they couldn't find the NG tube, then they did the air insufflation test, which is seeing this whoosh of air as they describe in their paper. We can see that even before the air, there's already some amount of clear fluid that's present in the stomach. And then injecting air into it just obliterates everything in the field of view and helps decipher that the NG tube is present inside the stomach. I've put a QR code for an editorial about the same paper that I really liked, and it talks about all the things that were done really well in the study and takes a really good critical review of the paper and their approach. And I think it adds a lot more value to the paper than just reading it alone. So I'd encourage people to look at this editorial as well if they were going to read the paper that we talked about. There are some other approaches that have also been described. This was the other approach that had been talked about in 104 critically ill patients using a 4-point method. So these 4 points include looking at the esophagus in the neck and visualizing distension of esophagus, then looking at the epigastric area to confirm passage through esophagogastric junction, which I find incredibly hard to find myself personally, and then looking for positioning in antrum and looking at the fundus to see if you can see the NG tube directly. They used this 4-step method and then used X-ray to confirm tube placement, found that with about 40 hours of training per intensivist, they could achieve 100% confirmation. That seems like a really long time to train somebody on a specific skill in ultrasound. But it took only 10 minutes to perform the ultrasound. So that seems reasonable to me. These were the images that they shared from their paper. The first picture is that of a paramedian view of the neck, where you see the trachea distended by endotracheal tube, and then to the side of it is the esophagus with an NG tube. Here's the gastroesophageal junction towards the lower edge of the liver. And you can see this double-walled structure here. Again, in the gastric antrum, you can see the not the nasogastric tubes. Yeah, excuse me, nasogastric tube. And then finally, the last part is the fundus, which they just show with some amount of fluid with some air bubbles mixed into it. So personally, I find this a little bit harder to follow through than the other one, which seems a lot more straightforward. But all in all, I think an easy skill to pick up and pretty useful. The last thing I wanted us to go through is this meta-analysis of 14 adult studies and over 1,800 patients that looked at a few different methods of ultrasound-guided NG tube placement and had pretty robust test results. There's a pretty good clustering of studies around here, which only adds to the fact that more or less the studies had very similar numbers with a few outliers over on this side. That's all I have today, and I'm happy to take any questions or any comments that people have about this.